Dear students, welcome back and starting again. Now, there was one question pending for physiology, and that was about the skeletal muscle contraction. And when does the skeletal muscle ends? This ends when there is decrease in calcium outside reticulum. So, fall in calcium outside reticulum ends the muscle contraction. Now, just in brief, we can take the changes in the sarcomere at the time of muscle contraction. Yes, you are right, Rakesh. So, during a muscle contraction, if we look at the histology of the sarcomere, we know that there are three important areas. Is myosin, is also known as the dark band. So, this myosin, then there are red lines, something, and then we have thin filaments. The entire length of myosin, it is known as the A band. Entire length of the distance between the tip of two thin filaments is known as, and the distance between the tip of two myosin filaments known as. Yeah. So whenever there is muscle contraction, there is no change in the length of myosin as such. So it means A band remains. What narrows down is H zone, and the during muscle contraction, A band remains as it is, but H zone, A band, it shortens, narrows down. Please remember, in relation to muscle contraction, which is the sliding actin filament theory, muscle contract. Yeah. Now we can move ahead to pathology. A lady came with the history of knee joints, and on microscopic examination, you saw needle-shaped crystals which are negatively birefringent. What is this condition? Yes, totally right. This is gout. Negatively birefringent needle-shaped crystals. And what is the arrangement or the shape of crystals in pseudo-gout? Yes, positive birefringence, and these are rhomboid shape. So if we wish to differentiate gout from gout, you have to few terms. Number one, the commonly involved joint involved in gout. Which joint is commonly involved? Is first great toe. In cases of pseudo gout, larger joints are commonly involved. Knee. Number one. Number two, on microscopy, the shape of it is, yes, very good, Nidhi. So in case of gout, it is needle shape, whereas in pseudo gout, rhomboid shape. So this is negatively birefringent in gout, birefringent pseudo gout. Then the substance in cases of gout, it is monosodium rate, whereas in pseudo gout, it calcium pyro. Here, so please remember at least these 3 points whenever we are differentiating pseudo. Yeah. So whenever you find the word negatively birefringent, think of gout. Now here the confusing point was knee joint pain, because knee is commonly involved in pseudo gout, but going with the other features, case is more suggestive gout. Yeah. Yes, Pratusha, you are right. Now another question: dystrophic calcification. Dystrophic calcification. Yes, Rinkesh, Pratusha, Nidhi, Raghu, everyone is correct. The answer is arthrosis. Again, also ABCD, Chiki. Again, we have to distinguish 2 conditions. One is dystrophic calcification. Another entity, metastatic. There are 2 points based on which we differentiate these 2 conditions. Number 1 is the status of, and number 2 is the calcium levels. So in dystrophic calcification, the tissue is dead or degenerated. In metastatic calcification, the tissue is normal. And then in cases of dystrophic, calcium levels are normal, but in metastatic it is. So this is how, based on these 2 points, you can differentiate it from metastatic. Yeah. So dystrophic in atherosclerosis. So any condition which will cause raised calcium levels, it can be hyperthyroidism, that will lead to metastatic calcification. Just the basic difference between. Now, next question. A known case of diabetes mellitus. He had pigmentation over the arm, and he is also having micronodular losses. Biopsy is showing iron deposit. Most likely, yes, everyone is correct here. The condition is hemochromatosis, and in hemochromatosis, what you see that there is pigmentation. There is pigmentation. Usually, this is bronze, brown colored. There is diabetes mellitus. Therefore, collective term is bronze. We also use the bronze diabetes, and yes, there is of iron load, which is on iron deposits. Patient can have micronodular, in which the size of nodules is less than 3 millimeter. This is micronodular. Yeah, so this is hemochromatosis, and chromatosis can be primary or it can be secondary. Primary, and there is no specific cause. Secondary, it can be because of if so this is hemochromatosis. Very good, Raghu, very good. Now next question. Patient has massive splenomegaly. PLC was more than 88,000 cubic millimeter with immature cell. Philadelphia chromosome was also present. What kind of mutation you will see? Clinical condition in consideration is, this is which condition? Answer is A. Of condition is very good. So condition is CML, and characteristically you can see a massive enlargement of the spleen, so massive splenomegaly. In Philadelphia chromosome is 22. So this is a balanced reciprocal translocation. Means yes, from 9 some amount part will go to 22, and from 22 equal part will come 9. So that ABCL BCR translocation. That is very suggestive of yes, ABL BCR translocation. P99 to. So this is typical description for CML. Always and always you will see splenomegaly. Next question. Certain tumors secrete some chemicals or hormones which can affect various functions of the body. This is known as, yes, this is known as paraneoplastic syndrome. And to understand paraneoplastic syndrome, especially is related to lung tumors, sometimes they release a hormone, a substance that is known as PTHR. This is growth hormone related in. The action of this substance is similar to parathormone, which is normally released in the body, right? So the parathyroids are normally releasing the parathormone, and this tumor is also releasing a substance which is acting like a parathormone. What will happen? The activity of two will lead to excess activity parathormone that will manifest as hypercalcemia. Clear? So the parathyroids, they are working normally. It is just because this tumor is also secreting a substance identical to parathormone, so there is overactive parathormone. Yes. So we can see any sort of syndrome, but just an example to define paraneoplastic syndrome, and especially related to squamous cell carcinoma of lung. This is paraneoplastic activity. Paraneoplastic. Next question. What we will see in a case of sickle cell anemia? Yes, glutamate to valine at beta 6 of hemoglobin. So in beta chain at 6th position, there is replacement of glutamate by valine. It is known as point mutation, and absolutely right. So this is point mutation resulting in hemoglobin S. Point mutation. Which of the following is not true for anemia of chronic diseases? Which of the following is not true for chronic diseases? Yes, Raghu, Nidhi, Yes, if you are correct. Raised total iron binding capacity. It is a feature of iron deficiency. Very good, Raghu. So raised TIBC is a feature of iron deficiency anemia. Just raised, this is a feature of iron deficiency TIBC. Just remember ADA. Now, which of the following can lead to transitional cell carcinoma of urinary bladder? Which, now the term is transitional cell carcinoma. Now this schistosomiasis is not the right answer to this condition, because schistosomiasis leads to squamous cell carcinoma urinary bladder. The answer here is to naphthylamine toxicity. 2-naphthylamine toxicity will lead to transitional cell, and schistosomiasis results in carcinoma of the bladder. Okay? So don't mix up, please. Next question. Elderly male, low back pain, there is bony lytic lesions, raised serum calcium value, and on electrophoresis we see that albumin is not, but gamma globulin is increased disproportionately. What is this condition? Yes, everyone is right. The condition is multiple myeloma. So again, you can see elderly person with low back pain, then bony lytic lesion, that is, if you do skull X-ray, you can see out lytic lesion, right? There is hypercalcemia, this hypercalcemia, raised gamma globulin electrophoresis. All goes in favor of multiple myeloma. Clear? Then next question. A hypertensive lady has skin hypertension. He had high cortisol levels even after giving a high dose of dexamethasone. What can be the reason? This. Now here again you have to, everyone is right, you have to apply the concept of paraneoplastic activity. In is happening that, of course, this is a classical case of Cushing syndrome. It seems a classical case of Cushing. But even if we are giving high dose of dexamethasone, cortisol levels are not decreasing. It means the ACTH is coming from where else, which is not controlled by the pituitary system. Right? So it means it is coming from some other place, and that is ectopic ACTH secreting tumor. So this is again a paraneoplastic activity. Normally what happens if we give high dose of dexamethasone, it should suppress the axis. So if there is no suppression of this, yes, so this is ectopic ACTH secreting, no response to high dose dexamethasone test. One kidney is normal, another is contracted with scars. What will be the diagnosis? One kidney is normal, another is contracted with scar. Kidney is contracted with scar formation, shows previous routes infection. Can you answer? Will be the answer, better answer here? Chronic pyelonephritis. One kidney is not affected at all. chronic pyelonephritis is the right answer. And you can see small kidney with multiple are. Other kidney remains unaffected here. That is very important to understand. Only the infection, only the kidney which has undergone infection will be shrunken and it will show scar or pits the surface. Another question, patient is having hyperpigmentation and there is high risk of development of skin cancer. Firstly, tell me what condition you are thinking of. Yes, Rinkesh, you are right. What conditions you are thinking? That is right. Xeroderma. Right. Condition in discussion is xeroderma pigmentosum, and which is because of the defect in nucleotide adhesion repair, and they have this development in cancer. Right. So xeroderma pigmentosa. Then next question, 15 years old girl with weakness and she had pallor, icterus, spleen is palpable, normal MCV, increased and reticulocytosis. Osmotic fragility test is positive, Coombs is negative. What can be your diagnosis? So let us evaluate the words. There is LR, it means low hemoglobin. It is icterus, it means there is jaundice, which suggests there is increased bilirubin. And what is the source of bilirubin? Bilirubin is actually coming from breakdown of. So it might suggest that this breakdown of RBC. Then the spleen is palpable. It means spleen is enlarged. It is being more than normal MCV, raised MCV. Now MCV suggests what? MCV suggests size of RBC, and MC is the contrast. So normal MCV means the size of the RBC is normal, neither it is small, neither it is. And if I say increased MCSC, means the cells are more darker or lighter. Yeah. And then reticulocytosis is again one more feature of hemolysis. Means the body is producing more RBCs, time to compensate for the loss of RBCs. Because now osmotic fragility test is positive, it means when the RBCs are placed in NaCl solution, they are liable to get hemolyzed. And Coombs test is negative, it means there is no antigen or antibody mediated destruction of. So the RBC destruction has no immunogenic role. Now with this all presentation, the best answer which we can make out is hereditary spherocytosis. Right? So this is hereditary spherocytosis. Because MCV is normal, so we can rule out anemia. Coombs test is negative, so we can rule out autoimmune hemolytic anemia. G6PD deficiency, especially that may result in hemolysis drugs like primaquine or Adaptation. So better answer comes out to be the spherocytosis. Much of this we have part 1, like on days. Okay. So this is hereditary spherocytosis. Next question. Lady has breast cancer and the biopsy is showing tumor cells with signet ring appearance with mucin deposit. Indian file pattern. What can be the diagnosis here? This is invasive lobular carcinoma. So don't go with the word mucin deposition. Only you have to take this word into signet ring appearance and Indian file pattern. This is invasive lobular carcinoma. Now, for this invasive lobular carcinoma, you have to remember one more thing, that it can be bilateral. So if you see a patient having a tumor in, suppose, the right breast, and on histopathology, if there is the lobular variety, then do not forget to evaluate the left breast as well, because it can be. Now, what actually is this signet ring appearance? Thing like nucleus is here. This is the signet ring appearance. Here, look in the page, signet ring. Invasive lobular carcinoma. Yes, nucleus at the periphery. Now, a patient having jaundice has high levels of unconjugated bilirubin. What can be? Very good. This is Gilbert syndrome, and we take the metabolism bilirubin. What happens whenever there is? Will liberate hemoglobin. Hemoglobin is liberated. Now, globin goes to the gene pool. Heme is broken down into biliverdin and finally into bilirubin. Here, now this bilirubin is taken to liver, and once conjugated, is sent through common bile duct in part of duodenum. Here, this is the root. So, if it remains unconjugated, then we will say that it is unconjugated bilirubinemia. This is seen in Gilbert. Here, unconjugated. Just remember two conditions. One is Gilbert, another is Crigler-Najjar. So just remember two conditions: Gilbert and Crigler, unconjugated. Of course, you can remember hemolytic as well as physiologic jaundice. Next question. Characteristic feature of hemolytic anemia. Anyone? When we say hemolytic anemia, RBC are bent down and products leakage, they binds with, right? What should happen to haptoglobin? Levels of haptoglobin, because it is all neutralized. What will happen? Decreased hapto. Okay? Perfect. Decreased haptoglobin, feature of hemolytic. Next question. Lady with weight gain, constipation, lethargy, and hoarseness of voice, and she is having anti-thyroid peroxidase antibodies. What will be your diagnosis? Yes, Raghu, you're absolutely right. This is Hashimoto's thyroiditis. Now, the classical presentation, if you see here, weight gain, constipation, lethargy, this is existing hypothyroidism. So, Hashimoto's thyroiditis classically presents as hypothyroidism. Yes, Prithvi. This is Hashimoto's thyroiditis. Going to the next question. Hemoglobin is 9%, MCV is 65, RBC distribution weight is 6, platelet is okay. What additional finding will you see in patient? So in such a case, first you have to make your diagnosis. Yes, right. So see, this is hemoglobin is less, MCV is also less, this is high. So this goes in the case of iron deficiency anemia, and in a case of iron deficiency anemia, you will see raised PI. Perfect. Is raised PIBC. MCV, the normal value is in 80 to 100. Should be. And red blood cell distribution width, it should be around in how you can remember. Now, next question. A lady has a malar rash, is positive anti-Smith antibody, and there are small sterile nodules over the heart wall. What is the condition? SLE, because you can see here this is by rash, the Smith antibody. We have typical on either side of the heart valve vegetations. This is the ligament sac. Classical presentation. Next question. In a person who is having progressive renal failure past 3 years, we can see glomerular and vascular deposition of pink amorphous material which shows apple green birefringence under polarized light with Congo red staining, which are positive for lambda light chains. What can be diagnosed? Yes, the condition is amyloidosis, but it is seen in which of the following option? This is multiple. This is multiple. And here you can see that the person is going into chronic renal failure. This description is again amyloidosis. Yeah. So this is primary variety. You are saying amyloid light chains. AL. Primary amyloidosis. Now, if we talk about the tuberculosis thing, this can give rise to amyloidosis, but that is in secondary amyloidosis chains. Okay. This is secondary amyloidosis. In fact, secondary amyloidosis is seen in chronic inflammatory condition. In which conditions we can see chronic infections like tuberculosis, chronic bronchiectasis. So this is secondary amyloidosis. Yes, Raghu. So, and double A. Next question. Lady is having progressive dysphagia. we have thickening of the oral mucosa, whether like she is hypertensive with limited exercise capacity because of lung fiber. What can be the diagnosis? Yes, this is scleroderma. This is a classical picture, scleroderma. You can remember the crest syndrome, sclerosis as well. Thickening of skin. Yes, it has been mentioned, leather-like. Next question. Patient has, a lady has, very important, erythematous butterfly rash, cheeks. Which antibody will you in this case? Yes, this is very basic, anti-double-stranded DNA. Typical case of skin, case of, you will find anti-double. Next question. Chronic smoker have intermittent claudication. Initially, the pain was at movement, but now it is also happening at rest. So, what is the diagnosis? I think everyone can answer this. This is Berger disease or trans. In first session, we have already discussed the concept of claudication. Now the patient has gone into rest. Here, so this is Berger disease and smoker, male. Next question. 6 years male child with sore throat, developed hematuria. Vitals were normal, and parents said the urine was like most likely diagnosis. Classical description for PSGN. There is a history of sore throat and hematuria, that is nephrotic syndrome. Classically, the color of the urine is like cola colored nephrotic syndrome. And next question. Elderly patient has been working in the dye industry for over 30 years. Now he is having some symptoms related to urinary bladder, like hematuria, frequency, urgency. What can be the condition? Everyone is right. This transitional cell carcinoma of urinary bladder, and frequency means increased number of times patient has to urination. What is this word? Urgency. He can't tolerate. He will rush for urination. These are the two terms. Then again, if you find the term squamous, your answer has to be, your condition has to be cystic. Just make sure aniline dye. This is classical description, transitional carcinoma. Patient is working high industry. Next question. Child is having fatigue, lethargy, pallor, and he is a known case of iron deficiency anemia, who is already taking medication. Now, before starting IV iron supplementation, what investigation you would do? Yes, everyone, right? We will go for ferritin. And why ferritin? Because ferritin is the iron. They are the iron, yes, storage form of the body, and that specifically reflects the amount of iron in the body. Ferritin has to be done. And if needed, then only go for any IV supplement. Ferritin, check ferritin. Next question. A patient had died because of suspected MI. And when you will do biopsy, you will stain the heart tissue with TTC, that is triphenyl tetrazolium chloride dye. Now, the viable myocardium means not dead. How it will appear? Yes, it will appear red, and the dead will appear slightly pale. Look here, this is all the viable myocardium, and this is octave area. Okay? So this is with TTC, meaning heart with TTC. Okay? Yes, of course, this is coagulative. Next question, we have already discussed in first session. Elderly male with low back pain, osteoblastic injuries. What will be your answer? Everyone can answer nicely. This is carcinoma prostate, because usually the osteolytic, but in carcinoma prostate it is plastic metastasis. Yeah. Next question. Patient had, when you do blood parameters, you found that MCV was less, MCHC was also less. Now, what kind of anemia is this? If MCV is less, it means the RBC are of small size. If MC is less, RBCs are having less contrast, means they are hypochromic. Here, this is microcytic, this is hypochromic. So answer will come out to be hypochromic anemia. Yes, everyone is right. This is microcytic hypochromic. Now, next question. Elderly patient with thrombocytopenia, neutropenia, and erythrocytopenia. All the cell lines are decreased. Spleen was actively enlarged. There is high number of blast cells. And what translocation can you expect? Yes, the classical case of CML, we will expect of 9 to, very good. This is CML. The moment you find massive enlargement of spleen in relation to any leukemia, always think here it has to be. Next question. Lady with abdominal mass investigated, and she was found to have bilateral ovarian masses and surface is smooth. And when pathological examination was done, we found that there was mucin secreting cells with signet ring appearance. What can be the diagnosis? Very good, Raghu, very good. Krukenberg tumor, and this is actually no, this is the typical signet ring appearance. We can see the nucleus which is at one corner, one portion appearance. Now, what is Krukenberg tumor actually? Suppose this is stomach, lower down we have 3. What happens? Tumor cells of the stomach can directly drop to the surface of ovary. Therefore, the signet ring is having the same resemblance as that of the malignancy. So the tumor cells are directly dropping the. This is tumor which is metastasizing in a very unique manner. It is directly dropping over of ovary, and therefore surface remains. So this is Krokenberg tumor, and please remember the signature appearance. Very good. Now, the next question. There are electron dense deposits with hyalinosis and sclerosis with diffuse loss of foot processing. Here, if you simply focus on diffuse loss of foot processing, might be wrong. You have to consider hyalinosis well. Therefore, your answer will become yes. Very good. Consider both the entities. So, hyalinosis with, you can see this is hyalinosis and there is effacement of the foot processes, podocytes. That is FS. Please, yeah, you are right. Now, next question. A patient presented with arthritis, enlargement of liver and spleen, increased pigmentation, and raised serum ferritin levels. What diagnosis can? This is again a classical presentation for hemochromatosis. There is arthritis, enlargement of liver, spleen, increased pigmentation, brown colored pigmentation with excess iron storage, that is ferritin. This is hemochromatosis. Wonderful. And next question. 35 years with bleeding gums and fatigue. There is marked leukocytosis in 70% of the cells. They are having myeloperoxidase positivity. Very good. This is classical description for AML. And remember, this age is very important here because many times the AML and ALL, they have the same time of clinical presentation. It is just based on the age we can differentiate, because ALL is commonly seen in the childhood and AML in adulthood. And of course, this is myeloperoxidase positive. You can see also roads as well. This is AML. Yes, AML. Chronicity is very usual presentation of hepatitis. One usual presentation of, very good, this is hepatitis C, and in hepatitis C we rarely see acute presentation, and just because it is a chronic condition, sometimes most don't even know whether they are with hepatitis C. Yes, very good. You can say C is better than, because some cases of can go into chronic phase, but majority they recover. C is better answer. Better than. The next question. Patient presented with hemoptysis and hematuria, and there is antibodies against glomerular basement. What is the answer? Yes, everyone is right. This is Good-Pasture syndrome. So here we have anti-basement membrane antibodies, which principally affects lungs, knees. Therefore, the patient will develop crisis out of blood and hematuria in it. So, Good-Pasture, very good. Next question. Ground glass hepatocyte. The moment you find the word ground hepatocyte, the answer has to be is hepatitis ground glass hepatocyte. Next question. A patient with cancer of bowel developed massive proteinuria, and there is subepithelial deposits. There is massive proteinuria and subepithelial deposits, and this is feature of, if you just focus on massive proteinuria, you might be wrong. You have to take this fact into consideration also. So the better answer will become membranous glomerular. So you can see there is deposition immune complexes that give rise to the subepithelial, not MCD, because important feature given is subepithelial deposit is membranous glomerular, MGN. If you stick only to massive proteinuria, you might be wrong. You have to look for subepithelial deposit as well. Yes, in minimal chain disease, what? If you do light microscopy, what are the findings on light microscopy? It is absolutely normal, and therefore this condition was erroneously named as minimal chain disease by just looking at the light microscopic features. But when same light was connected to electron microscopy, it was noticed that there is basement footprint. Right? So just looking at the light microscopy, it was normal, so it was called as minimal chain disease. Right? Was the history behind this nomenclature. But electron microscopy, you will see that the foot processes, they fuse, flatten. Subepithelial deposit, please remember MGN. Yeah. Next question, everyone can answer this. We have already discussed where we need to remove the spleen. When we should remove the spleen, first session is hereditary spherocytosis, the condition where the RBCs are spherical in shape. As they try to pass, they are broken down. So if you want to prevent hemolysis, you have to sacrifice spleen, right? So splenectomy should be done in, again, with the preoperative pneumococcal vaccination. Next question, there is history of jaundice for 10 days. Bilirubin levels are high, SGOT, SGPT are high, alkaline phosphatase high, and the patient is positive surface antigen. If you want to make a diagnosis of acute hepatitis B infection, what other thing you should check in the patient? Yes, you can go for anticore antibody, and even DNA PSR is also okay. They have two good there in ANC, both can be the answer. Both can be the answer. But whenever we do, we commonly follow this in routine clinical practice. We routinely do anti-HBC variety for recent. We can also do HBV DNA PCR, which also tells about the infectivity. But clinically, we prefer IgM anti-HBC. Can do either of the two, but routinely we do IgM anti-HBC. Clear? Next question. A young male presented with history of infertility, recurrent episode itis with bronchiectasis and situs inversus. And this is very basic. This is Cartagener's syndrome. And what is this situs inversus? I think everyone must be knowing it. Organs change their side. Means the heart will towards the right side, liver will go on. So side is changed. And there is bronchiectasis, that is normal dilatation. Sinusitis, infertility, ineffective ciliary motility. So this is Cartagener. Yes, Aninda, you are right. They are on the opposite. Next question. Surface antigen is positive. IgM anti-PC is positive, and envelope antigen is also. What will be the diagnosis? Surface antigen, then IgM, anticore antibody, and also envelope antigen is positive. What does this mean? Very good. Means these two say that the patient is having acute inflammation virus, and this tells us that the patient is highly high viral load. The better answer will come out to be acute infection with high infection. Here, next question. Years-old child with hematuria and RBC cast in urine. Basic. The answer would be hematuria, RBC cast is PSGN. This is nephritic syndrome. PSGN. Very good. Nephritic syndrome. Then during the window period of AIDS, what diagnostic test? Window period when around 3 months time. The answer is PCR. PCR. The routine tests like ELISA, Western blot, they are not positive during the window period. So RT, PCR, and we can also go for P24 antigen, but the best is RT. During window period, ELISA, Western blot, they are negative. Right? So best is RT. RT-PCR seems a better answer here. P24 can be done.